We're broadcasting live at this time from Studio Envision, as we refer to our large conference room at Envision, New Mexico. And you're connecting online, and it sounds like somebody else has also. So please introduce yourself. Let us know you're on the line.
And I believe it's Glenda Kanaka, and she's having some trouble being heard from her end. She can hear you, sounds like, but she's not able to send her voice to us. So something's going on there. We just tried reconnecting and...
Oh, can you hear me now?
Glenda?
Yes, can you hear me?
Yes, we sure can.
Yay! Hi, I'm
Glenda
from the Prevention Research Center. Yeah, I've been here from the beginning, but I couldn't. For some reason, you couldn't hear me.
Oh, that's right, and now we can. So welcome, Glenda.
Thank you, and I just want to apologize in advance because I have another meeting that I have to attend. But I didn't want to miss at least a little bit, so I'll be leaving around 12:30 if that's okay.
Okay. Well,
Sorry.
I appreciate you announcing that. Certainly, you'll be able to attend the didactic portion of today's TPICC.
Okay, great.
Glenda?
Yes.
Am I understanding correctly that you got to hear that Rosario's on the line as well?
Yes, I did.
And that Rosario is joining us from Santa Fe?
Yes.
And Glenda's joining us here in Albuquerque from UNM.
Okay. Hi, Rosario.
Hi, good. I'm glad you're getting to meet. And pardon me, I'm reminded again about the need to pause. My need to pause because the way our telecommunications operate, as we find with our cell phones, for example, we can begin speaking to another topic or a point that we're making before everybody else has gotten to hear it. So you may notice me pausing from time to time because I want to make sure you've heard my preceding statement. Okay?
Yep.
It sounds like somebody else may have joined us.
Yes, this is Kathy Mezoff in Gallup. I was trying to just do it online, and I wasn't hearing anything, so I thought I'd better call.
Welcome, Kathy.
Thank you.
And it sounds like somebody else may have just joined us as well.
That's me, Nancy from Las Cruces.
Hernan, welcome.
Thank you.
For the rest of you to know, Hernan is a pediatrician in Las Cruces. Kathy Mezoff, I remember you, Kathy. Have you continued to practice pediatrics in Gallup?
Yes, I do.
Welcome.
Thank you. Sorry to be late.
So am I.
I'm grateful that you're with us now. Also with us are Glenda Kanaka, who is a physician scientist at the Prevention Research Center at UNM, Albuquerque North Campus, as well as Rosario Torres, who is a social worker with Via Therese Catholic Clinic in Santa Fe. So I'm thrilled that you're all on. I'd like to ask Rosario, Glenda, and Hernan, if you would mind if I give a brief orientation to Dr. Mezoff about TPICC.
No problem.
Go ahead.
We had just been talking about this. Dr. Mezoff, TPICC is our acronym for Telepsychiatry Pediatric Integrated Case Conference. Usually it's held the first Wednesday noon hour each month, as it is today.
Okay.
Oriented primarily for pediatric primary care providers.
Okay.
With an aim of assisting providers with the clinical management of their patients' behavioral health issues, and approaching that in an integrated fashion. Our format is similar to other telehealth conferences that come out of Envision, New Mexico. The little bit of difference being that we have a shorter didactic section, about 1/4 of our session is intended to be didactic, with 45 minutes of case conference. However, we haven't had submitted cases, so we've ended up spending more time on the presentation, including its discussion.
Okay.
So we broadcast from the large conference room, fondly referred to as Studio Envision, here at Envision, New Mexico. And anytime you are in Albuquerque, that you are going to be near or in downtown, you're entirely welcome to join us at Studio Envision.
Okay.
There's a registration beforehand. A case form is submitted for the case conference. For those who submit a case form, I will write recommendations and send them back to you following the conference. It will basically capture what we discussed. Everybody's eligible for a CME if you're attending the case conference to the roll call toward the end.
Okay.
And Molina Healthcare is now reimbursing providers and really reimbursing the clinics for the presentation of Molina patients.
Oh.
We received some support also from Molina Healthcare for TPICC, as well as from the New Mexico Pediatric Society. And moreover, we have announcements in New Mexico Pediatric Society and Envision New Mexico emails, and you may have read about us in the NMPS publication.
Mm-hmm.
The history of TPICC goes back to when I first met Dr. Metzoff, when we had a teleconference to talk about the assessment and treatment of ADHD, which actually back in 2005, that resulted from a partnership between New Mexico Pediatric Society and Envision New Mexico that allowed pediatricians from around New Mexico to get on a speakerphone, get on the telephone, and we would have a conference with multiple lines. So now we're able to do it at least through this format, and we may have ways of doing this through further video modality in the future. Oh, while I shift back to today's opening presentation, does anybody have any questions about TPICC that I can address?
I'm okay over here.
Sounds good. Well, again, welcome to TPICC. We're on the air to welcome you here. And I decided it would be really fun today to have an opportunity to talk about The ways that we go about combining medical and behavioral health practices to integrate pediatric care. It's something that many of us are very interested in doing, and we find that we often have kind of fits and starts and stalls and various ways that we end up getting hung up and wondering how we can do this better. I introduced myself previously. I'm at UNM Pediatrics as a board-certified child and adolescent psychiatrist, providing direct services in the UNM Pediatric Clinic and its school-based health centers. And I also provide consultation to providers around the state. And I can tell you a little bit more about another way to access that on a case-by-case basis at the end of today's presentation. I mentioned earlier that there is a CME offered for your participation today, and there is further information packed into this slide about the reimbursement that is available from Molina Healthcare and how to go about coding for that. That will be included in the slides for today's presentation that will be posted in a downloadable fashion on our website. So following today's presentation, I think by this afternoon or tomorrow morning, PowerPoint slides will be posted there. You can open it up to look at it there, or you can download it and print it if you want. And it will include this detailed information. Our goal in looking at how to combine medical and behavioral health practices to integrate pediatric care is to understand and bridge the differences between the ways behavioral health and medical providers practice. That is, how providers think and know and do. Really in epistemology, if you will. Our objectives are to describe 3 ways that medical providers traditionally have practiced, 3 ways behavioral health providers traditionally have practiced, and then to discuss the combined medical and behavioral health practice that integrates pediatric care. Because there have been differing clinical epistemologies, if you will, traditionally speaking, between medical and behavioral health providers. And I don't claim to be telling you new things or all new things about this, but really bringing it together for purposes of a discussion. It's been known that the ways of understanding and performing clinical practice have differed traditionally between medical and behavioral health providers, with different approaches, methods, rate, specificity, certainty, and thought processes that will be compared and contrasted in just a little bit. It impacts making assessments, providing treatment, and conceptualizing patient conditions, including their diagnoses and their needs. Meanwhile, pediatric providers practicing in teams have bridged these differences to ultimately integrate medical and behavioral health care for their patients. So our main task in looking at this is to compare and contrast ways that medical and behavioral health providers traditionally have practiced. There are similar and differing approaches and methods for providing care, from first meeting our patients through assessment to treatment. Now, the following distinctions between traditional medical and behavioral health practices are for presentation and discussion purposes. That's my disclaimer. They're going to be shown without any intention of describing your particular current clinical practice. In other words, we're stereotyping to make a point. Traditionally speaking, the differences in clinical provider approaches have existed between, again, medical and behavioral health providers, including methods. Medical providers approach patients and examine them through their physical exam after taking a history, and both medical and behavioral health providers will take histories. Medical providers will proceed with the physical exam, whereas behavioral health providers perform a mental status exam. Now we know that there are medical providers often conducting at least portions of the mental status exam. But again, we're making these distinctions for purposes of the presentation and discussion. And we know that most behavioral health providers are not performing physical exam, but they are making observations that end up being documented in a physical exam. In the provision of medical care, instruments are used, whereas in behavioral health care, the provider becomes the instrument. There is a therapeutic use of self, if you will. But we also know that medical providers, especially pediatricians, end up doing that. Medical providers perform tests and procedures, whereas in behavioral health, traditionally, the procedure performed is being with the client. The rate in medical practice is faster, whereas the rate in behavioral health, at least initially, is considerably slower. The thinking in medical health care involves a process that's more decisive and linear, whereas in behavioral health care, it's more deliberate and broad. The content of thinking is much more mechanical, such as plumbing and tubes of the cardiovascular and digestive tract systems, respiratory system, genitourinary system, lots of tubes. Whereas in behavioral health, the content is much more psychosocial. It's theater at times. And that came actually from a consultation liaison psychiatrist who bridged both worlds, who taught in the medical school that I attended. He said he loved psychiatry because it's theater. He liked theater more than plumbing. He made that distinction. So I don't take the credit, whether you like the analogy or not. And that in the thinking, there are differences with regard to the certainty and specificity of that thought content. Traditionally, medical providers have greater degrees of black and white thinking, if you will, that's more absolute. Either the patient has a urinary tract infection or a gastroenteritis, or they don't, okay? Not to claim that pediatricians get those things confused, but there either is the disease or there isn't. Whereas in behavioral health, there tends to be less certainty, a tolerance for greater ambiguity because there are more gray areas to appreciate and tolerate. The nosology, descriptive aspects that lead to diagnoses. In medical care, the patient becomes the diagnosis traditionally, whereas in behavioral health, the person has the diagnosis. So for example, the child with asthma becomes the asthmatic who is similar to other asthmatics, whereas in behavioral health, each person's depression is unique. Now, I know that many pediatricians would agree with the uniqueness of everybody's depression, or each person's depression. But again, needing to make these distinctions. The treatment in medical practice traditionally has been more protocol guided, whereas in behavioral health, traditionally created for the individual. and that is, especially nowadays, within care standards. Now, if you were to look at the protocols that are created and distributed and promulgated through the American Psychiatric Association, as well as its child psychiatry counterpart, the American Academy for Child and Adolescent Psychiatry, you very well may say that psychiatry is also protocol guided, and it certainly has become more protocol guided since its early days, and certainly by the time I wrote a paper about this in the late 80s. Psychiatry was already becoming more protocol oriented, which actually had to do with some of what I was doing in writing that paper and making these distinctions today. So in thinking about the epistemologic differences, we can look to Melville, who wrote about Moby Dick, saying, "The whale, therefore, must see one distinct picture on this side and another distinct picture on that side, while all between must be profound darkness and nothingness to him." Which to me really makes a wonderful metaphor about how traditionally we've often had a chasm, if you will, between the medical views and ways of thinking and knowing and doing on the one hand, and those in behavioral health on the other. Fortunately, over time, we're bridging that chasm. And Moby Dick's eyes are they're moving toward the front of his skull and face, rather than being so distinctly apart. And binocular vision is evolving in how we view clinical conditions. By the way, there's an interesting piece of intellectual history that I just want to comment about as an aside. Melville wrote Moby Dick when there was a debate about the wave versus particle aspects of light, and that scientists were conducting experiments that yielded results causing them to conclude that light was a particle, and others were designing experiments yielding results that described a wave aspect of light, which I thought was a really interesting part of Moby Dick. Well, how can we effectively bridge these practice differences that I've been talking about Moby Dick doing in developing binocular vision, and doing that within our clinical teams to integrate patient care? Pardon my typo. This becomes our next objective, and discuss how we do that. Well, in combining or bridging these differences, we value the integration of medical and behavioral health care. We put the appealing theory into sensible practice. We find in our practice-based evidence that we evolve in our respective practices, and we're finding an evidence-based practice in the literature, if you will, of medical and behavioral health care integration, that we understand, appreciate, and complement other providers' clinical epistemology that really refers to other disciplines. And we can do this in regular team meetings, and when we train together, when we attend conferences together. And more, we find a number of disciplines at our conferences which can really result in wonderful opportunities for us to discuss these issues further away from our busy practices. I hope you'll find that TPICC is a forum to do that too.
And I'm
we can
sorry,
also
what does
familiar. Go ahead, Hernan.
Yeah, I missed what PVE means. I'm sorry.
Practice-based evidence.
Practice-based. Thank you.
So how we determine in our practices. Some things mentioned here have been practice-based evidence versus evidence-based practice. We can also make the bridge by familiarizing ourselves with and follow developing integrated care policy. And we're going to touch on these points. Starting with valuing the integration of medical and behavioral health care. As Sharon Stephan at the Center for School Mental Health, University of Baltimore, Division of Child and Adolescent Psychiatry, and Laura Bray at the National Assembly for School-Based Healthcare wrote in School Mental Health, integrated and collaborative care refers to an innovative healthcare model wherein primary care and mental health care providers partner to deliver care within one particular setting, with the intent of delivering more effective and efficient care that allows providers from different disciplines to consider the holistic needs of an individual and to share information with each other. They also make the point that primary care and mental health professionals alike are calling out for better integrated care delivery, really delivery systems that reduce the limitations and inefficiencies encumbering our current system. The World Health Organization, interestingly, as listed in the references, wrote a monograph in 2008. Well, they published a monograph along with the World Organization of Family Practitioners, pointing out that other countries successfully have integrated mental health services into primary care. The American Academy of Pediatrics has put forth that families of children with mental health needs are looking to primary care providers as their source of and gateway to mental health care. As mentioned previously, it's about reducing inefficiencies in care as well as in cost. Reese Brennan has pointed out that collaborative care practices have proven to be more economically efficient in the long run. Brosco published in 2003, in the future, integration of pediatric and behavioral health will require that systems of care do not perpetuate myths about the distinction between the two fields. It is clear at both a biological and psychosocial level. Distinctions between physical and behavioral health are, I'll say spurious at best, and generally impede attempts to maximize child health and well-being. And that comes out of Stephan's and Bray's paper as well. And they also point out from Reese and Brennan about advocating the philosophy behind the collaborative care approach. Physical and mental health issues are inextricably connected and therefore should not be treated as distinct health problems. And inextricably connected is so important theoretically, and it really has valid underpinnings to why we end up seeing, I'm going to move ahead, diagnoses frequently comorbid with depression and anxiety in our pediatric clinics include asthma, overweight, as well as substance abuse and pregnancy. It's been found that depression in many individuals who have a biologic basis for depression involves an inflammatory state, and that's what prevails in overweight and asthma. So there really are these conditions with intertwined medical and psychosocial etiologies and risk factors that result from integrated care, because they themselves are intertwined. They're inexplicable. Surgeon General stated that the mind and body are closely connected. Probably singing to the choir in which we stand, but the point of getting to the U.S. Surgeon General publishing this in 1999 was big. So what about separating mind from body? Not. Well, the separation of mind or psyche from the body, referred to traditionally and historically as soma, has become a useful, convenient construct for conceptualizing illness and appropriating care. But really, it's about how illness is explained, and thought about, rather than what's really going on in the child or adolescent. And it's also about appropriating care. We have a separate behavioral health carve-out in Medicaid, for example, and that's a whole nother managed care entity from the other salutes. The separation of body from mind, again, is pointed out by in Stefan and Bray's paper. The separation limits effective health and mental health care. And without care integration, psychiatric comorbidity can be under-recognized during primary health care, and conversely, medical problems under-recognized during mental health care. Consequently, because there really isn't this separation, not only are behavioral health providers such as myself practicing in pediatric and school primary care settings, but there also are primary care providers now going to mental health care venues to bring in medical care to those who usually only will go to their behavioral health provider for care. Historically, the Greeks believed that physiologic and mental health states are determined by a mixture of the four humors. And it was in the 70s and 80s that Dr. George Engel, an internist who became a psychiatrist at University of Rochester, developed the biopsychosocial model, initially to explain heart disease, asthma, and eventually other illnesses. And subsequently, by the time I was training in psychiatry, it was being applied to depression, anxiety, and other psychiatric conditions. Already talked about the inextricable events going on in the body, involving both body and mind, that lead to these intertwined medical and psychosocial conditions. So the combination of medical and behavioral health practice integrates pediatric care, because the integrated whole person orientation is valued and practiced in primary care more and more through the biopsychosocial orientation of pediatrics, family community medicine, nursing, and psychiatry. And school-based clinics are exemplary among this. School-based health centers have shown what ideal locations they are for integrating primary care and mental health collaboratively. Let's see. I'm actually quoting here from the National Assembly of School-Based Healthcare. And I got off their quote a little bit, but they're basically saying that the school-based health centers are the ideal location for primary care and mental health staff to collaboratively address students' physical and mental health needs, leading to greater success in school and elsewhere. And that's what we see. School-based health centers have really demonstrated to us how well this can be done. And ultimately, they offer high-quality mental health care by using an integrated strategy for addressing health as well as mental health issues. So school-based health centers aim to integrate medical and behavioral health care in order to assess and treat youth comprehensively. And many of us who practice in school-based health centers have come away from these sites believing this can also be done in the pediatric clinic. There's some entities that have set standards for integrated care in school-based health centers, such as I mentioned, the National Assembly on School-Based Health Care, as well as here in New Mexico, through the Department of Health, there's an Office of School and Adolescent Health. We find that beyond our school-based health centers, integrated care is appreciated by not only school providers, but educators and families. And by the way, school providers would be the school counselor, the nurse, the social worker. And that we find that integrated care, again, is compatible with the biopsychosocial model that we find is so clinically useful. And integrated care has become endorsed by our professional organizations of pediatrics, family practice, and now the American Medical Association. Just heard its president, Denver psychiatrist Dr. Jeremy Lazarus, talking about this last month at the annual meeting of the American Psychiatric Association, who last year made integrated care the theme of their annual meeting. It's also endorsed by the American Academy of Child and Adolescent Psychiatry, the American Psychological Association, the American Academy of Nurse Practitioners, as well as physician assistants, social workers, American Counseling Association, and the World Health Organization, along with the World Organization of Family Doctors. So more and more integrated care is being valued and endorsed by our respective professions. Now, I'll just briefly clarify that there was actually research done to confirm each of these. And when calling or contacting the American Counseling Association and the American Academy of Physician Assistants, they agreed, yeah, we really don't have it stated on our website and in our literature yet, but fundamentally, based on our values and recommended best practices, yes, we endorse integrated care. It's also being looked at for policy development, going back over a decade to the Surgeon General's Healthy People 2010 report and the President's New Freedom Commission on Mental Health during the Bush administration. Common elements in integrated care that cross disciplines include the approach of treating the whole person, that the integrated care venue be a focal point for delivery of all care, and that there is a requirement for care coordination and collaboration, and often training across disciplines. So in summary, ways of understanding and performing clinical practice have differed traditionally between medical and behavioral health providers. Differences in clinical approaches include methods, rate, and thinking that have been described in the listing. Provider differences impact making assessments, providing treatment, developing treatment plans, and conceptualizing patient conditions and needs. And pediatric providers from various disciplines can practice in teams, bridging these traditional differences to ultimately integrate medical and behavioral health care for their patients. Any questions, thoughts, concerns, comments, beliefs, or even protests?
This is a nun from Las Vegas. Yeah, it's an interesting concept. Kind of goes back to what I remember being taught in medical school, that health is the complete welfare, physical, mental, and social welfare of the individual. And here we are dealing with the first two aspects of that. And although I did see in that you do integrate some social workers into the issue, but the point that the comment that I was trying to make is the fact that both physical and mental health in our society today are being greatly influenced by socio-economical aspects, the issue of pregnancy, the issue of drug abuse, the issue of unemployment. There's so many other factors, social. So this integration, I think it's a very necessary integration, but it appears to me to be like the first step. It certainly will not be complete until we find some mechanisms of also influence the social, economical aspects of delivery of healthcare. I don't know if that makes any sense to you. No.
Well, I certainly appreciate the comment, Hernan, and commentary. I think you make a very important point about there being social and economic issues that come into play in determining one's health and well-being. Would you say that is compatible with what you just said?
Exactly. That you put it in a nice short phrase, what I blabbered about for a long time. Yes, that's exactly it. Yes.
I appreciate you elaborating more on that. I think it's an important reminder, an important point.
This is Kathy in Gallup.
Yes, Kathy.
Do you hear me?
Yes.
Well, this is very interesting to me since I left the practice of general pediatrics 9 years ago and just am trying to do behavioral pediatrics now and trying to somehow, I guess, in my own practice, combine the two to some extent. Although as I've gotten older, I do less and less physical medicine and more behavioral. So, I think these are critical issues.
When did you say you left your general pediatrics practice?
I stopped doing that 9 years ago in 2004 and began just doing behavioral pediatrics. But I don't have a fellowship or anything, so I'm kind of on-the-job trained.
Appreciate the reminder of your practice.
Yes, and as I'm looking toward hopefully maybe retiring in the next couple of years, I'm trying to help educate my fellow pediatricians about some of these issues. And it's very difficult in a private practice. I mean, I schedule a lot more time for my patients, and I have the luxury of having 45-minute appointments to help deal with these things, but most pediatric practices can't do that.
I think that is one of the key elements in the difficulties of integrating things for the delivery of care.
Yeah.
Is the fact that you're talking about two styles of practices, one of which has by tradition become you're seeing 6, 7, 8 patients sometimes in an hour's time.
Yes.
And so that affects, I think that has many difficulties that it places on the integration of mental and physical health care, behavioral and physical health care, is the fact that the regular pediatrician probably doesn't have that much time sometimes to ask the questions even.
right.
and of the potential problems. But not only that, he doesn't have the time for that, but he doesn't have the time either to communicate with other specialists. That is,
Right.
Sitting down together to have a conference on a patient
Yes.
is a demand of time.
For me, as a social worker, this is Rosario.
Yes.
It is also important to be aware of environmental factors that may be influencing, that go beyond just socioeconomics, but also pollutants or other things in the environment that may be contributing to asthma or depression or any of the, or substance abuse, for instance, but also belief systems. Not only individual belief systems, but family or community belief systems, spiritual life, and how that may translate into behavior. So for social workers, understanding the whole person goes beyond the mechanical functions of the body and mind. Does that make sense?
Oh, you were just
I
saying
think it
that
does.
to understand the person goes beyond the mechanical function of the body and mind.
Yes. We're not just machines. There's other parts of who we are that are influenced by beliefs that are not based on the mechanical body, so to speak. And I'm not talking about religion. I'm talking about issues of, self-worth, self-esteem, etc.
I'd like to comment on that, but I'd like to ask if Hernan or Kathy want to comment on that as well, or if Glenda's still on the line. I kind of doubt Glenda is at this point.
Well, I guess you're commenting about the environment, and you mentioned a lot of different influences on the person and health. Is that your emphasis?
Integrated care goes beyond just the physical body and the mind, is what I'm saying. I mean, it's important, it's crucial, but we can't forget that there's other things that influence human behavior.
Right, like the social and all kinds of environmental issues, social and cultural and all that?
Yes,
Yes.
and beliefs. The belief system of that individual and that family.
Right.
And I'm not talking about religion. I'm talking about spiritual beliefs that are tied into self-worth and, where that person sees himself in the whole world, so to speak. Am I worthy of blah, blah, blah?
Right.
Right.
Especially
That would sound to me like it would be something that certainly would fit into the behavioral aspect somewhere along the way. But
behavior
maybe
is
what
not
I agree with the most with is the fact that this thing really extends beyond what we visualize as being the mechanics of physical medicine and the process of behavioral medicine.
Yes.
It affects everything.
Yes, a person is more than just behavior and their physical body. There's things that, we're learning in the evolving field of neuroscience that, are going to change how psychiatric diagnoses are made. Right?
I think so. And as you were commenting about there being more to this, I'm thinking about how a little bit different terminology comes to my mind as this is discussed. What you're talking about, the function of the mind, I think about as the function of the brain, and the brain being an organ of the mind, and that we are only we've only begun understanding the mind through some understanding of the brain, but there is so much more to it.
Yes. Yes.
And to understand to believe that one understands the mind because of brain science is really a rather reduced belief and perspective of the mind.
Yes.
I very much appreciate your comments, and somebody was just speaking. Go ahead.
I think we would go backwards if we would lose all the work that has been done to get to the point where we're really thinking of integrated care. If we go back to just thinking that the mind is what controls everything. I'm not disagreeing. I'm just saying that there is so much more that we have to understand about what a human being is, or who we are as human beings, which there's a piece of having a soul, but we don't discuss that because it can't be proven, quote unquote, scientifically. But we have a soul.
Good point.
We wouldn't see the kind.
No, it's a very good point.
Okay.
No, I think it's a very good point. I continue to think of that as part of the mind, that the mind encompasses the spiritual beliefs that you mentioned and the soul, while the brain is the organ of that mind that we can begin to understand, but we are so limited in what we understand about the mind.
Right.
I'm noticing the time. I've appreciated the discussion. We're getting toward our ending time of 1 o'clock. So I want to make sure that I mention that there are references that you'll find in these slides. Ordinarily, we do have cases that are invited to TPICC. That's the point. We really want to have an opportunity to integrate care and have discussions of integrated care. If you do have cases that come up in the course of your work that you would like this psychiatrist consultation about, that can be arranged by contacting Clancy here at Envision, New Mexico. That's her telephone number and her email address. I continue to have about 4 hours a week available for telepsychiatry consultation, ordinarily involving the telephone or speakerphone. These hours are in flux right now, however, as the school year is over, and it can vary even week to week. Next week I'll resume doing some work in school clinics again. Our next TPICC session will be on Wednesday, July 17th. We're choosing the third Wednesday in July, thinking that July 3rd is not going to be a very popular Wednesday for TPICC People are going to have other priorities. So please submit your cases. Think about cases you might have. And there will not be a TPIC in August, but we will resume on Wednesday, September 4th during the noon hour. So I thank you for joining today, and I think we have roll call for you taken through your participation for Rosario, Hernan, and Kathy. Thank you so much for joining us today.
Thank
Thank
you.
you.
Very helpful. Thank you.
Yes. Thanks.